On the left side, Dr. Jack Zigler, who looks mighty mean with his crossed arms, and Dr. Scott Blumenthal on the right, who has a very skeptical glance on his face. He's portraying leisure, and Dr. Rick Geyer is going to moderate what we're going to see. So this is the promised showdown, left and right, dual dissections, 2 C-arms, 2 cadavers, 2 instrument systems, and 2 great surgeons. Dr. Geyer, can you man the microphone and set off this competition?
All right. Are you guys ready?
Yep.
Scott, you ready?
Which one of these are you going to use?
Get away from Jack's table.
Use this one probably.
That's cheating.
Yeah, but we're not going to run this as a race. We're going to slow it down a little bit because I'd like to show you my technique for finding the midline and doing the discectomy, and then Scott will show you his technique because I'm hoping there are some subtle differences and you can pick what you like of all those. So we're not racing to the finish line. This shouldn't take us a long time to do it.
I've already marked it.
Let me just show you on this cadaver. Can you see the images there? Yeah. So there, it's critical to find the midline. And if you can show the overhead view, do we have an overhead view of the spine? Yeah. So, here's the top of the lumbar spine coming down now. This is L4-5, which is the disc we'll be using. So this would be the patient's right side, rather. So their vessels would be laying here. Bifurcation could be variably somewhere around the L4-5 disc. L5-S1's a little bit easier because then you're between the iliac vessels, although sometimes the left iliac vein can be across. At L4-5, the anatomy is very different, but assuming that your vascular surgeon can get your vasculature reflected towards the patient's left side, and your job, and I'm standing usually on the left as the surgeon, is identifying where the disc starts to round down. So you want to identify the lateral margins of the disc space. So I usually just watch and see when it starts to fall down on the easy side, on the patient's left side, and then make sure that my access surgeon is showing me the same thing on the more difficult side, the right side. I have to be able to see where that starts to drop down so that I can really envision where I think the midline is. And then that's what I've done here. I use the little midline marker that's in the ProDisc set. In surgery, we are confident enough of our levels, usually, that we use a screw so that we know the head sits right on the disc space, and then get a good AP. Before we've started anything, we also get an AP to make sure that the patient's rotation is neutral at that level. And sometimes we'll have to airplane the table. Here, we airplane the specimen a little bit, but our AP film shows us a pretty true AP, and we've got the marker in place, and then we look at our lateral film to verify that we're at the correct level. So then I'll usually use a Bovie, but you can also use a marking pen like we've done here to mark the end plates above and below. The mistake we all made at the very beginning was we would draw it on the disc annulus, which is coming out in the next step. So you have to do it down to the end plate, and that's why a Bovie mark in the end plate gives you a memorialized marker of where your midline is. And then you can, whether it's a screw or this particular instrument, there it is, you can take that out. So then the next instrument is a knife. And again, usually I'm coming from the patient's left side. I'm mindful of the vessels that are on the patient's right side. So I'll always try to cut away from those vessels so the access surgeon doesn't have an MI in the middle of the case. And I also work hard to try to find the interface between the end plate and the disc. And I'll cheat and look at my lateral film, and I can see here that the hole I made is more close to the L4 end plate than the L5 end plate. So I'm going to feel with the knife, and this is the surprise working on cadavers. You never quite know what you're going to get, but I can finally get into some soft tissue here. So I'm on the patient's left side. I'm kind of working cross-handed, and I'll try to show you, but I'll be cutting towards an edge where there's generally not going to be a vessel coming across. I'll go down, try to keep my knife so that the belly of the blade is not threatening any blood vessels, come down until I can contact the superior end plate of the L5 body here, make my turn. And again, you try to do all this nice and controlled, again, so that your access surgeon doesn't...
Hey, Jack, Can you just give them an idea of how far out? Is it 1.5 centimeters from the midline, or is it 2? What is your guesstimate?
Yeah, great idea. All right, let me take the knife out. So the left side's cut. So here's what you can do at the beginning. These are the two sizes of the ProDisc end plates. One is a large. This one's a large, and this is the medium. And it's not shameful to kind of lay that on your midline mark and see, do you have enough exposure of the vessels on one side or the other? Your goal is always to put the largest end plate you can fit because you want the best contact with the apophyseal ring. You don't want to be just sitting on the middle of the end plate in the cancellous bone. So we always try for the larger size. Usually you can get a pretty good idea from looking at the patient's X-ray and their height and their overall size, but we always are limited by patient's anatomy. So if the access surgeon says, I can't get that vessel over anymore, this is all that I'm comfortable giving you, then you're going to use a medium. But if you put the medium down and there's still plenty of room, it's again not a foul to try to put a large on. And if you're still safe within the vessels, then you can mark that boundary on the patient with a marking pen and shoot for that. In practice, I try to get as much as I can to the dangerous side, the patient's right, and then mirror that on the less dangerous side, the patient's left. You always want to be as symmetric as you possibly can. One of the mistakes that I see fellows make all the time, and that I made when I was starting out here too, is to make an eccentric annulotomy. Once you lose the midline and you lose symmetry, you spend a lot of time chasing that back down. So it's a lot easier to always stay symmetric, centered on the midline, and get the maximum out that you want. So then the job again is get to the interface of disc and end plate with your knife and safely do a rectangular annulectomy that will box out that interface. So I'm going to let Scott take over, show you his tips to get to this level, and then come back and I will have it boxed, and then I'll show you my tricks for separating disc from end plate, and we'll flip-flop that way.
Okay. Can you see my cadaver? I've already marked the midline, and like 90% of the world, or actually it's like, 90% of the world, I'm right-handed, so I stand on the right side of the patient. I just find it's easier to work this direction. In terms of the annulotomy, at the beginning, I agree with Dr. Zigler. Take a trial out and see how wide you have to go. The reality is you can go a little less than the width of the implant because you're going to kind of scallop out the disc from underneath, and leaving a little extra annulus can only help you anteriorly, where you're not going to most people don't reconstruct the ALL. I do
some bone in there.
100% agree. Symmetric,
I'll
disc
peel
space,
one out with another knife.
incision.
Good.
Always cut away from the vessels. So right to left at
even need to
L4-5, and then towards the midline at L5-S1. Keep it symmetric. And you can start to separate the disc from the end plate with the blade. And then what's kind of a cool trick, and the fellows by the end of the year are always very, very proud of this, is to try to get as much of the disc out as possible on kind of your first pass. And the key to that is to use the cob elevator. And you take the cob right along the end plate, and you just kind of stay subperiosteal. And in a non-frozen human being, kind of goes pretty easily. This specimen's a little cold on the inside. It's all right. We'll make it work. And you do the lower end plate, the upper, in no particular order.
Surgery actually goes a little easier. You don't have to tap it because then that normal tissue separate a little easier.
And make sure you don't dig into the end plate. It's just nice subperiosteal dissection. Okay. And just kind of loosen it up. See what?
And what he's doing, he's twisting it to cut the corners. You see what he's doing? And And then it's going to show you how he's going to lift the whole thing out.
Yeah, that one probably.
Maybe.
And then it usually sticks in the back corner, so you just kind of got to loosen it up a little bit. And I don't
You can
know
also use your Cobb elevator,
well,
just
and
angling it towards the feet to come across the upper end plate, and that'll help to loosen it as well.
push pretty hard. There you go. Like I said, I'm going to push pretty hard.
I think they super glued that disc in.
And it's loosening up pretty well. And let's see how much of the disc we can get out. Huh? Yeah, I'm just taking the initial part of the disc out. You can try to get as much out as possible with your subperiosteal dissection, and then just get the corners cleaned. And you can get a good chunk of the disc out at once. Now, what kind of big curette we got? Now, we don't have one here, but I like to use a ring retractor and then just move back and forth.
I like to use it as well. I think there's less chance of going through the end plate if you just tilt it
bigger
up
ball.
a little bit. And the goal here is to get those end plates pristine, free of all
He's got a bigger
cartilage,
bowl.
maybe.
Oh, you got a ring, even better.
Kind of big
Sweet.
disc there, Scott. You're lucky.
You have to hold it pretty good. And the move is in the disc space, is back and forth. And because if you slip, you just slip to the other side, as opposed to coming out this way. You could drag a vessel and make your access surgeon very unhappy.
And again, the ring prevents you or lessens the chance of
Scott,
perforating.
can I switch back while you're finishing?
Yeah,
cleaning
pass
that?
it over. Huh?
Okay, can I just show them separating disc from end plate?
Yeah.
Okay.
You want to take a?
If you come back to me, so we hit some either bony osteophyte on this side or some frozen bone, and I broke the knife blade off in there, so it's going to come out with the disc, but I just need to be a little bit ginger. But what I do is I like to take my Cobb and identify the interface between the bone and the disc. And for the upper vertebral body, I'll usually reverse the Cobb like I have here and find that bony interface and then follow it down. Just ride the bone, and that'll separate out most of the disc from its attachment to the end plate. And then I'll reverse it when we go to the lower part of the disc space, find that little interface, and I'm riding the bone. So, what I don't want to do is glide and be in the middle of the disc. That doesn't help us. That's going to leave us with too much stuff to clean out. The whole goal here is to try to prevent all the repetitive pituitary entries into the retroperitoneum. So this way I'm trying to separate as much as I can at each end plate margin by using that cutting edge of the Cobb. And it'd be nice here if I could find that knife blade before one of us gets clobbered, but we'll work on that. And then sometimes you can just turn the corner and use the sharp edge of the Cobb to separate the lateral annular fibers the same way, or you can do that with a knife blade, or sometimes a smaller Cobb. But I'll just do a maneuver like that using that really sharp peripheral part of the Cobb. Let me see if I can get it in focus. There's like enough of a lag that it's making me nauseous too. And use that sharp part to make the turn and cut those fibers. And every once in a while you can be a hero and be able to deliver the disc almost completely as one piece. So just let me get that back corner, and then we'll get a pituitary and start to get it. And then, I'll lever down a little bit when I'm 2/3 of the way there and try to get under some of the main disc material. So let's see, we'll get a pituitary and see what we pull out with, and just remember that we got a knife blade in there. Thanks to Raytech. Get me one of those. Thank you. And I try to teach our fellows to make a habit, and it's my habit already, always have a rag in your non-dominant hand so that you can clean your own instrument, so that you don't have to lift your hand out, give it to somebody, bring it back, refocus, bring it out. it'll save you a lot of mileage in your career if you just keep doing the wiping by yourself, by keeping the rag in your non-dominant hand, especially doing like a decompression or a laminectomy, where you're going back and forth a lot of times. Just keep watching out for that. Like, there it is. Hey, we found it. Somebody want to grab a clamp or something? Larry?
Breaking a blade off inside the disc space.
Well,
it's
it's
not
either
a common
frozen
thing, but it's a little nerve wracking because you don't want to push it into the canal.
Yeah.
So
Hey, okay, rescued. So that's done. So then I'll just keep trying to separate and follow and see what's holding me up, and remove as big a fragment as you can. And again, this is just saving 100 passes in and out of the disc space if you can take a lot of that gunk out altogether. So that's a major part of the discectomy. And then you're just following it up with the loose pieces that are hopefully also separated from bone. So, the idea is again, limit the amount of passes, because, if it's a heavy patient, you got a lot of soft tissue, you're passing by the back of the peritoneum, the ureter could be impacted, and obviously the vessels. So we're just trying to clean stuff up. When I think I'm 2/3 of the way there, I'll usually just put the closed pituitary down and ask for a lateral film. Here, get your hands out here. We take a lateral, and sometimes you're 90% of the way there, like I am now, which is fine, but you want to know that before you're in the spinal canal. So I always try to discipline myself before I think I'm to the back, take an x-ray, so that'll give me an idea. So you can see I'm about 80 or 90% of the way back there. Scott, where are you? What level are you at? Are you at PLL yet?
Say that again?
Are you at the PLL?
Yeah, that's what I'm just cleaning out on one side. I'm waiting for the other side to
Okay, do
demonstrate.
you want to show them anything, or, because I'm about to put my distractor in, unless you want to skip steps.
Yeah, come on
why
over
don't you tell
here.
about the retractor you have in there, the laminar spreader.
Thank you. Hey, thanks.
Scott,
All right, so the
Scott,
move
Scott,
that
do you see
Dr.
the-
Zigler was showing is once you get
that.
back to the posterior annulus PLL, is to release the posterolateral corners with a curved curette. And I'll try to demonstrate. Actually, bring the lateral in here and I'll try to demonstrate.
Scott, talk about the distractor that you have in there, how you're doing that.
So there's two different type of distractors for the
I gotta
disc
clean
space.
it up
There's
a little
a
bit more.
central spreader, which some people call the David spreader, and then there's
just
these
work on
unilateral
curette.
spreaders where you can just work on the opposite side. And it comes. I think they all come with all the sets. And what it does is it allows you to clean out that posterolateral corner, contralateral, to where you put these smaller. Here, we'll get that out of the way. Because it's real important. It's not your ALIF discectomy. You really have to get all the way back and do a release. And if you remember your orthopedic residency, it's like doing a total knee. You got to balance the ligaments. So I'll try to show you to get in that corner.
Thank you for
you need that curette around the back.
Yeah, these end plates are not good.
And there it is. It's around the back and it's in the corner.
You didn't see the
and all it's
X-ray.
doing is releasing the posterior annulus.
All right,
You
a
don't
little
have to get
comment
a, you
about
don't have
the
to get a
retractor.
Kerrison in there and resect it all down because there's some big epidural vessels that live back there, and it can
Just
cause
a
some
point for
very
the audience
laudable
about
bleeding.
the laminar spreader. You really need to get that back to the posterior margin. If you squeeze too hard, you may perforate the end plate, and that is not a good thing. You perforate the end plate, you compromise the support for the artificial disc. So it needs to go all the way back to the posterior margin.
Yeah, you really need to, and that's the biggest mistake that we see is inadequate discectomy,
X-ray?
particularly posterolaterally.
Okay, so I need a little bit more.
How do you rescue that if you
One of these curettes.
if you actually do perforate the end plate? If you find out that with your spreader there,
Thanks.
I use a spreader that's a little wider than that, but if you do actually break through that subchondral bone or that end plate, then how do you rescue that?
Rick, will you answer? Because I couldn't hear most of the question.
Actually, I was looking at the chat. You
were talking about perforating the end plate. How would you rescue that? Would you do a cement augmentation? Would you try and have the disc more on the apophysis? Because it's typically not the apophysis that would get perforated. But how would you rescue it if you did perforate the end plate?
I think it depends. Most of the time, if it's just a few millimeters, then you're going to have the support of the entire end plate bridging that. In reality, I can't remember a patient, even in the very beginning, where I violated the end plate and said, say, oh, I need to. The key is it's a very careful technique. It's not a swipe and grab with the pituitary clean out. You have to be very, very careful. That's why I like the ring curette, as Scott showed. You just tilt it up a little bit, and you cannot perforate the end plates. If you make a big divot, say it's 25% of the end plate, then obviously you have to do a fusion. I've never seen that. I've never seen any of Scott, Jack, myself, or Jessica ever do that, and we had to salvage it with a fusion. But we want to just make the point to those people starting out not to do
ring again back there. I have it. Yeah, and your bailout, Sig, if something really goes awry, is make sure the rep always, and a good rep knows this, always has a backup A-lift cage. It happens. I think way less than 1% of the time you got to call an audible intraoperatively, but you don't want to get caught not having a backup cage.
The big curette. I got it.
All right, Jack.
Yep, so I am cleaning out. I've got one side cleaned out to the PLL, and I've actually dropped a little curette over it. And now I've put the second curette, the second ProDisc distractor into that side. I've moved over to the other one, and I'm just cleaning out the other corner. And usually the corner that is insufficiently cleaned out is the corner that's on the surgeon's side. We usually do a better job looking across the table than we do looking underneath our chin. So I always kind of try to remember that, and whatever side I'm on, I lean over and make sure that is nice and clean. And as Scott said, we're trying to do a complete discectomy all the way back to the visible PLL, and then we're actually going to drop over it. I always release the PLL on every case, and I rarely take the PLL unless I'm looking for a fragment.
Let's cheat.
There are other surgeons who always take the PLL in the lumbar spine, just like we always do in the cervical spine. And we actually looked at the range of motion outcomes of our patients postoperatively, and they were the same. So for me, that means don't look for trouble, basically. But it depends on what you're comfortable with in your technique. But you don't have to remove the PLL, but almost always you have to release it because most of these patients have contracted disc spaces, which means the PLL has contracted down over years, and you want to get a good parallel distraction. So you're gonna need to release that sleeve.
Hey, Jack.
Yep.
We got a question from the chat room. Actually, it's from Antonio, one of our former fellows, Antonio Webb. Wanted to know how you work them operating graphically. What studies do you use? MRI scan, discogram, PET scans?
Every patient practically comes to us with an MRI. A lot of them come from the primary care office. They've never had an X-ray, but they've had MRIs. So I'd say all of our patients get X-rays, including dynamic X-rays, including flexion extension to rule out instability. They all have an MRI to look at. I think we underuse CT scans. We should probably be a little bit more liberal in getting CT scans because they sometimes will show pathology, as you showed on that case with foraminal osteophyte, as we see sometimes with more facet disease than we thought was on an MRI scan. So I think it's a good idea to get CTs, and we're all are also trying to correlate Hounsfield units with T-scores until we're a little more comfortable. So I think we should probably be getting CTs on most patients as well. So if you can show the lateral image, so I'm back across the posterior margin. I'm releasing the PLL now, starting in the midline where it's safer to be in the canal, and then just working my way towards each corner. And
Jack, what happens if you go too far lateral?
There's not a lot. If you go too far posterolateral,
posterolateral.
Yeah, you can get a nerve root or get an injury. If you go straight lateral, there's not a lot that's an injury. The guys who are doing lateral X-lift type lateral fusions bust through all the time. So that's a relatively safe zone. But again, if you're feeling with it, that's why I like to go in the midline, and I tell the guys to use a kind of a twisting pronation supination maneuver as you go around until you feel it start to round up towards you again, and then you're coming up the posterolateral corner, but you're always hugging bone. The other tip is, or trick is, if you're operating on somebody who's had a couple of discectomies, go in the midline first, go to the unoperated side to open up that sleeve of released PLL, and then you have a nice area where you can then go back into the previously operated area and stay on the bone side of the scar and release the nerve root that way. So, go from unoperated to operated. So we've got reasonably good parallel distraction. We've got our PLL released, and we're going to do some trialing unless Scott's up to that step. Scott, what do you?
So I think Jack was discussing
let's see
in terms of sizing. I like using the CT scan, and I find that the most predictive aspect of the sizing
quick shot.
is anterior to posterior. So preoperatively, you template anterior,
large would be
posterior,
right.
and then
Just have to
90% of the time, that's
it
going to
back
be your
further.
size disc. This fellow
just wait till we come back.
templated
We'll do that one.
to a large,
clean
so
this
this
a little
is
more.
a large trial. Okay, we're seeing this. Okay, so here's the large trial. And it'll go marked cranial caudal.
Hang on
So
to
put it in the disc space.
And it's a 6 degree, correct?
This is at L4-5, so 6 degrees tends to be the most common size. And we'll knock it in. Let's take a picture.
Is it there or here? Okay.
Do we have a mallet or anything?
Yeah, hang on.
Oh, yeah.
And just to reiterate what Scott said, it's the anterior posterior dimension that is really your limitation because you want to get it seated properly. And sometimes on EP it may look small, but it might be limited by the
So
anterior posterior.
Yeah, so at L5-S1, I always try to get to the back of S1 just because of the orientation and the angulation of the disc space, because it tends to push the upper plate a little bit forward. At L4-5, you want the disc to be center to 2 millimeters center of the mid body, and then with prostheses that have a convexity like the activL does, you see how this is going to fit in the inferior end plate of L4. So this is I'm pretty happy with this positioning. So, but the only thing I don't know is I haven't checked an AP to make sure.
Can I see that lat?
Okay, so we're going to have to check
can show 'em
an
that.
AP. Yeah, we'll have to check an AP. And again, you want to be within 1 millimeter to 1.5 millimeters of the midline.
Scott, you want to talk about the spike fixation of the activL?
Yeah, so the activL has 2 modes of fixation, spikes like the original Charité did, and then a keel like the ProDisc does. So it gives you flexibility. You can use spikes, you can use keel, you can use a spike above and keel below. You can mix them up. And I don't know if you're allowed to say that, but it's kind of off-label. But you can do that as well.
And where would the spikes be on the little recesses on the trial?
I don't remember. Do you remember where the spikes are?
It's close to the first slot
Okay, the first slot. Okay.
or first notch. So you want to make sure that they are embedded in bone.
So we're going to try to get an AP here just to
Let me use the medium
show that we're in the
trial
midline.
first
I've kind of
and see if I can get that better
tried to
position.
get
And
a
we'll
little
cut it
rotation
and we'll
going
try
here.
the large
Try again. Try again. Okay. So this is the least rotated, and it's pretty much down the pipe. And I stayed on my mark, so I'm very happy with that.
Thank you.
And
And you have the screwdriver to get.
do you want to do your trial and cut your keel, or do you want me to put the disc in?
Yeah, let me switch back to this. I'll show them a
Okay,
couple
switch back
things
to Dr.
before we do it. Great. So if you can look at my lateral x-ray, so I've got the distractor in.
We can go back to lateral.
I try to get it back to the posterior corner, but there's either some osteophytes or ice or something back there. But you can see that we've got pretty good parallel distraction. You can use the tips of the distractor as an internal ruler. They're 3 millimeters thick. So no matter what the magnification is, you can always calculate off that. So you want to see twice the thickness of the tips in between the tips. Then you have 3, 6, you have 12 millimeters. So we can easily put a 10 millimeter tall implant and still leave 2 extra millimeters for patient motion. So I'd be okay with this, and we test fit a little bit. I think we can get a large implant in, but rather than fight it because the end plates are weak, I'm going to use a trick that Rudy Bertinoli showed me, because the midline slot in the trial is the same for the medium and the large. So I think we're going to use a medium trial. We'll put it in now into a good position, cut the slot over it, and then we can see whether we can get a large implant in that or have to go to a medium implant, but the midline channel will already be cut. So we're going to take out our distractor. We've cleaned out the disc space. Here's the ProDisc Medium 10 millimeter trial. It does have an adjustable stop on it, and those kind of like training wheels. We'll leave that in. Here's the value of having a midline mark that you can continue to find. So we know that we're putting it in on that midline mark. We'll look at our lateral x-ray and see where we are. So I need to tip up a little bit. I want to follow the curve, and I need to bring that stop out quite a bit. So each 360-degree turn with this, I don't know where you can see it, with this screwdriver is going to give me 1 more millimeter of ability of depth. So I need a lot. Right, so I'm saying about 5, 6 plus millimeters. So I'm going to move this out quite a bit, and now I'll impact the trial. And I'm hugging that lower surface image so I don't fall into that defect. So there we're moving. Let's see, and I want to make sure we're just about hitting anteriorly, so we need to release a little bit more. But I'm fairly comfortable that I'm on the midline, although we're going to check an x-ray with the trial in once we get it seated. And again, it's soft bone, so I'm trying not to do any damage in there. Image. So we're getting close. I'd like to be a little bit deeper. We might be hitting. Let me give myself another couple of millimeters, and I'll see if I can guide this in just a little bit more, and then we'll check an AP film. Image there. Yeah, that's about all we want to get now. And whatever that is back there is potentially holding us up. So this is not a bad position. It's a little bit undersized, but let's check our AP.
And that's not a true tangential, so you have to tell your X-ray tech.
Right.
And the other thing is you have to take multiple X-rays because you want the axis of the shaft to bisect the disc space, because if not, you could knock off a posterior rim of usually the upper vertebral body.
So here's our AP film, and the landmarks that I'm looking at are 3 things. I'm looking at the pedicles above and below, and I want to see where I'm sitting with relationship to the pedicles, because that pedicle circle is really the base of the pedicle, which is the back of the vertebral body, which is the middle column, and that's what we want to index this against. The next thing I'm looking at is the distance laterally from the implant to the lateral edge of the vertebral body, and I ask myself, is that relatively symmetric? The last thing I'm looking for, although it's the easiest one to look at with your eye, is the spinous process. Spinous process is what everybody keys on, but the spinous process is the fusion plane of the 2 lamina. It is at the back of the spinal canal. It's in the posterior column. A little bit of rotation will move that tremendously compared to how rotation will have a minimal effect on the lateral distance and on the pedicle distance. So those are much more reliable. So I'm okay with that. I think we're good. Laterally, I'd like to get a large in. So I would say we're going to cut this channel, and then we'll try a large implant.
And the other thing you can be fooled with, if you look on the right side of the screen, it's fairly prominent of the level above. So don't let that little spur or whatever fool you, because it looks like it's not centered, but it really is.
Chisel? Yeah, right. All right.
Jack, what are your thoughts about that little bit of coronal plane obliquity there? Would you try and actually release what looks like the left side of the image? Would you try and release that annulus a little bit more, make them more symmetric?
Yes, is the answer. Whether that will help the deformity or not, I don't know. Terry Marnay is pretty optimistic, and he's done a lot of them. Rick is a little more optimistic than I am. I'm a little more pessimistic that it will change things. But in real life, I would spend a little bit more time on the concave side trying to release that. Sig, yes.
So Jack and Scott, my usual questions, naive questions. So this is obviously a nice osteophyte-free disc. The first question I have is, talk to us about osteophytes. So when I see disc arthroplasty patients, they usually have pretty significant spondylophytes floating around, or not floating around them, marginating them. So making a true midline determination and an access to a disc a little bit more difficult. So how do you handle that? How far do you kind of cut those out, especially under the vessels? How do you then handle midline determination? You have to redetermine midline. So this is stay with spondylophyte resection in a severely degenerated disc, like what I think you, Jack, showed yesterday in your excellent lecture.
Yeah, no, I think you want to look at your pre-op films, and it's a place, again, where a pre-op CT scan can help you a lot. So if you see an anterolateral osteophyte, if it's on the vessel side, I would certainly bring that to the attention of your vascular surgeon for a couple of reasons. Number one is it's a chronic inflammatory process, and the vessel walls may be scarred down to it. But as my retired access surgeon tells me, there's also going to be a big drop-off as you retract the vessel if he's not aware of that. So that's something I would discuss with him beforehand. And I'd have a low threshold if we needed to use an osteotome to osteotomize that as soon as the vessel was protected. If it's circumferential, if you're dealing with a spondylophyte, that's all around, that's probably not the right patient for an artificial disc. That's probably a patient you should have made a fusion decision before. We don't see a lot of HO in the lumbar spine. In fact, it's really rare. But I think one of the reasons is we don't do a lot of bone work, as you see in the cervical spine, where sometimes you have to do circumferential, certainly posterior and even anterior anterolateral osteophyte removal. We worry a lot about those being HO generators. We don't have that issue in the lumbar spine, but I think we aren't as aggressive with our indications once a patient has collapsed disc space with big bony osteophytes all around. I think that would be, for me, more of an A-lift discussion. Scott, do you want to add to that?
Yeah, I agree. Obviously, the preoperative CT scan will tell you whether or not they're a good candidate or not. But as we've come along these 2.5 decades, we've taken on some more degenerative segments. So like Jack said, you'll know what to expect anteriorly, and if you don't know what to expect, your access surgeon will tell you, hey, there's a big osteophyte in the way. It's going to take me a little longer to mobilize the vessel, and then you have to make a decision intraoperatively whether that osteophyte stays or goes. I just think it's just more, in the other part of your question, Jens, you just have to be more careful to avoid rotation in the patient so that you can keep those landmarks that Jack was talking about in mind to keep to the midline.
Okay, so then I have a follow-up question to this, and then I'll shut up for a second to let you proceed. But I have a final question later, and that is how much collapse of a disc is too much for a disc replacement? And I'll direct that question at Scott first. So if we have barely a marginal disc space left, it's not fully fused, it's not fully ankylosed, let's just assume modic change present, but it's a severely collapsed disc, let's say 10%, something like that left.
That's going to get much.
What's the tide mark of collapse where you'll still consider disc replacement in the lumbar spine?
That's a great question, because in the early days, it was 50% or 75%. But as you become technically more adept at mobilizing, and I'll tell you the game changer, which I don't have an example to show you, is the David spreader, the central spreader. That's been a game changer. And, these 90% collapse, as long as their facets are reasonable and you can mobilize them, and intraoperatively, it just takes longer. You got to stay with it a little bit and work on it. We now don't even blink if we see a 90% collapsed.
And the key is, Jens, I showed a picture in my talk, but the key is in lateral view, you have to direct whatever instrument you use to get your release. Look at the image so you follow the disc space, because if you, for example, put a very fine spreader like we have for the ProDisc in that disc space, you have to make sure that you are along the disc space and not digging into the end plates. So you do it on the lateral.
So the one thing I want to point out about Rick's lecture, he mentioned that briefly, and I wish we could project that up, but maybe we can do it later in a discussion session, is the presence of an inferior L5 osteophyte. And I'd, again, love to explore this with SIG for isthmic spondylolisthesis. I do think that in these very collapsed discs, in presence of an inferior L5 osteophyte that projects into the foramen, redistraction alone can actually tension the nerve root and can create an iatrogenic radiculopathy that worsens. You showed that very nicely in your case.
And Jens, actually, having done many patients like this inadvertently by, checking, post-op CT scans, I have yet to go back and to decompress them. You can get them over it. The one I showed was the worst one. He was a patient from Canada, but
be able to
finally
show them
can nurse him along.
Yeah.
And I tell the patients it's always a possibility, but I used to think that was right, but it turns out clinically it's not.
All right. So
Can I make a quick comment?
Jessica has a
I
comment.
have a quick comment, and to your question,
I just was ready to go in.
about how much collapse is tolerated. One of the other things I think that really helps is, and I get a CT on all my patients for lumbar disc replacement. I think we've all kind of gone to that for various reasons, including looking at those spurs. But if on the CT you see vacuum disc phenomenon, even if it's like a 10% collapse space, that's a pretty good indicator that you're going to be able to remobilize that space. I think we've all kind of felt that way in our practices, and that's something that is pretty correlative to being able to restore the height. So just another thing where I think there's really benefit on the CT. So even on those really collapsed ones, and you're going to see the facets better as well. And so I think it's really important to get a CT scan for all these.
Yeah, it's just like the cervicals. We get CTs on all the cervical arthroplasties as well.
All right, so we're back on my side, and I've been standing around watching the other side do the beautiful, beautiful keel cut. But this prosthesis doesn't need a keel. You can see the spikes, as Rick alluded to, a bit, but 3 millimeters recessed from the front of the disc. So we're going to keep that middle spike on my blue mark, and we will insert this disc under the lateral.
Hey, Scott, make a comment about being able to steer this according to your line, how you can pull.
Say that again?
And how you can steer it, how you can pull the handle towards you or away from you if you're not exactly centered on your blue mark. For example, it looks like you're a little off, and you could just lean your hand and drive the implant over a little bit on an angle.
Well, until you lock in
You can tilt the holder.
Until you lock in your spikes, you can move, you can rotate if you're not straight up and down. So I'm going to try to keep it straight up and down, and we'll see how it looks. All right, see X-ray now. All right, so it's pretty much where I put the trial, the convexities in the concavity, and that's where I put the trial. So I'm gonna take that there, and we'll take it out and then check an AP and see if we're within a Geyer unit of midline.
Scott, building on Rick's comment with regard to being able to rotate that, have you had the experience where it's difficult to get at 4.5, for example, to get the vessel all the way across? And can you put this device, doesn't have a keel, in more obliquely? Can you do sort of almost an anti-psoas approach and put it in obliquely and then get it centered just with the handle, so you don't need the whole width of the device by the vessels?
Yeah, that's a great point. So unlike a keeled device, if you're getting a little bit inadequate lateral exposure, you can put this in somewhat off the midline, and then once you're ready to kind of set it in, rotate your hand up and get you back to the midline. You can play with it a little bit. It's not you've got to still get mostly a good clean out of your access surgeon to get good exposure.
Scott, that looks like a Geyer 2.0.
No, we're going to get a better AP
Let's
for
see
Scott.
AP.
Hang on. Watch your hand, Scotty. Shoot. Yeah, you want to?
Yeah, that's off.
Oh, 3.0.
And this is where the question becomes: Could you adjust that in situ without, if you had an oblique inserter?
No,
if you had an inserter that allowed for a vector to be at an angle, could you actually adjust it in situ because there's not a keel there holding it in place?
Yeah, but those spikes are pretty
if you
firm.
can get it out, if you can partially get it out, you could. But it's hard to get the inserting device back on. So it's easy. You just take a curette, get under one of the spikes, and just kind of get it out intraoperatively, and then just reposition. And we can do that while Jack's putting his in.
Okay.
Yeah, the one thing that neither one of you talked about, the table that we use a regular OR table, but we flip it around so we can drop the head of the bed, which is really the foot of the bed, and let the trunk help to open up the disc space. So if he has to replace that, by dropping the head, you're opening up the front, and you can get it out relatively easily.
Yeah.
It's in there pretty good.
All right, so let me switch over. Can you see our overhead camera now? Because we've got the disc space prepared. The cut is made. I made the cut with that medium. And now I'm taking a large footprint implant, and it's collapsed So there's no polyethylene in there. The leading edge is pretty thin, which is good, particularly in this situation where the bone is relatively soft. So I don't want to overdo it. Ideally, the other mallet, ideally I would have liked to put this a little bit more posterior, but we're running into soft cadaver bone. So I'm starting to advance it now. And the nice thing about a keel for me, whether it's an activL or ProDisc, is I know where it's going. I'm not going to be fooled on my post-op film because it won't drift at all, and I can use the inserter really just as a guide to just guide it down. And let me get it in a ways, and let's look at the lateral film. All we need on the lateral image is depth and trajectory. We have good control now over left-right lateral movement and rotational movement. It can't happen because the keel is engaged in the slots. So we've reduced 4 degrees of variability down to 2, which are controlled by looking at the lateral. Is this the large or is this the medium? It's large. Yeah, it's a large. Okay, it is a big disc space. All right, so if we put that in image there, so I'm following it down, and it turns out to be a really enormous disk space. So even though for the most part we try to put these indexed to the posterior margin, when I see a disk space this big and I've got my largest implant in, I'll usually try to visualize the line that runs down the center of rotation of the body and leave this just where it is. So leave it a little more anteriorly than keying back to the posterior margin so that its center of rotation is in the line of the center of rotation of the spine. So I'll give it just a little bit of love tap. At this point, we'll get our polyethylene button that has to be put in, and it's critical that this goes in the correct way. So the rep will tell us yeah, okay. There's a bubble on the top. The bubble is the convexity, and that's going to articulate with the superior metal component. There's also a straight line and a curved line. That's a dome as well. Behind the bubble, or behind the curved line, is the locking ledge that locks the polyethylene in. So the rep will always say dome up, meaning the convexity up to the patient's head, and the rounded portion up to the ceiling, because underneath that is the locking ledge that's going to be the last thing to go in. So that gets put in at the slides at the top of the inserter window. There are 3 ball bearings that will control the migration of the polyethylene, not allow it to go deep until there's enough distraction room that the upper arm won't bruise the top of the dome. So that's all designed in pretty easily. So when you put in the distractor, I'm controlling it from the top, snapping it in, and now I'm just turning the thumb screw. You'll see it starts to advance the polyethylene as it's distracting internally. There's nothing to see until it's about halfway down, and now it's starting to distract the disc space. I think you can see that. I'm going to take it all the way down, and then we'll get an image. In your first few cases, you can do it either under live fluoro or just intermittent images, but there's really nothing you're going to do until it's hard stop all the way down. And now we'll look at a lateral. We want to see some daylight, and that means we've done a good job with our distraction, and we'll be able to get our polyethylene in. If you can't see daylight like that, it means you've not done a good release. And then you got to take it out and go back in and dive in and do the soft tissue release. So that's a mistake you only want to make once or twice because it's just extra work. So do all your soft tissue work before so that you're happy with your distractors and your distance measuring. And then hopefully it'll be easy just like this where you have the room. And now the last instrument is going to push the polyethylene into the inferior component. And it's following the same slide that the polyethylene took. It's going past the ball bearings now. I'm going to mate it, and usually you can hear or feel a click. Yeah, we heard it here. And there's a little line that's etched on there that is collinear with the top of the inserter. I give myself the ability, and I tell the fellows, just thenar eminence or thumb is the only thing you want to do, because you don't want to fool yourself. At this point, inspect it really, really carefully. This is the surgeon's decision. Only the surgeon can see down there. You can't ask the rep, is it locked in? You can't ask the anesthesiologist. Only the surgeon can look straight down, and it's good visualization. You can see it. We do like you to take a probe or a Fraser tip sucker and just be sure there's no step off and no gap. If you're unsure, I'll put that instrument back again, and I'll just hit it with my thenar eminence. But I will never let somebody, hit it really hard. And here's the reason. If you haven't done a good release and it's not locked in, and you're frustrated and you want to get out of Dodge, you can do this. It'll deform the front of the poly, and then you can say, okay, it looks good now. There's no step, no gap. That will come out. You'll be visiting that retroperitoneum again in 24 or 48 hours. That's almost a given. So you have to be sure it's locked in. The flip side is, if it is locked in, it will not come out. So the surgeon needs to be sure that it's locked. But here, I don't think we can see down ideally enough, but I have really good visualization because the instruments are so streamlined that I can see that there is no step off, no gap, and I'm comfortable that we're locked in. I've taken out the inserter. Now I'm going to take out the distractor and make my final determination. We don't need this anymore, but I don't want to take off the inserter until I know I'm going to keep this disc, because right now, to get it out, I have a handle. If I decide after I take the inserter out that I don't like the position, I've got to go back in and try to line up my pins, which sometimes is easy, but sometimes in a recessed situation with redundant annulus, a lot of bleeding and a lot of frustration can be a pain in the butt. So you want to make your decision now, but now you have an unfettered look into the disc space. You know that the polyethylene is locked, and all you got to do is release the spring at the top of the tower, rotate these guys so that they're unlocked, and we're going to give it, one good shot from the side, and there's our disc. So,
and you can see how nicely the poly's locked.
Yeah, so you can see that there's just a hairline between the polyethylene and the inferior component. Can we see our lateral image now? Just make sure we didn't knock anything out. So it's where we put it. Let's do our AP, make sure that I haven't been lying to you.
You see the little dot on the lateral view that's within the poly itself, showing that it's locked. On the inferior end plate, that is, anteriorly.
Great.
Beautiful.
That's pretty centered.
Okay.
Dire zero.
Yeah, so if you look, under the, and again, don't go right to the spinous process. We look at some pretty person's face, and you look at their nose. The nose doesn't help you here. Look at the where it sits under the pedicles of L4, above the pedicles of L5, and how much lateral room there is. Those are your much better internal marks. So according to this, I might be a millimeter to the left, but this is nicely centered, and this one we'll take in a heartbeat. All right. Any other questions?
Okay. Any
Scott?
last minute pearls?
So one question I have for both of you is, and this involves Dr. Bervin again as
Thanks so much.
one of the senior colleagues in the deformity world, both SRS and ISSG. In the fusion world, there's been a great emphasis on lumbar cages to become hyperlordotic. And literally every manufacturer nowadays, for whatever the access strategy is, heavily promotes hyperlordotic cages. Lordosis is the long overlooked nirvana to kind of overcome the well-known iatrogenic fusion disease malaise of collapsed forward-tilted spines. Why is it not necessarily applicable in the lumbar disc arthroplasty world to try to emphasize hyperlordosis? Why 6 degrees at L4-5 when we cumulatively want to have 40, 45 degrees? Say, correct me if I'm wrong, there between L4 and S1.
Jens, and before they answer, I want to just say something. Even though the implant is saying 6 degrees, if we look at both laterals, you will see that it's actually more than 6 degrees. It has to do with the anatomy of the end plates. It's not just the anatomy of the disc. So, Scott and Jack, you want to answer? And can we show a lateral view of both?
Jack, come in the center. Show us your face here. Come a little bit more towards Scott. Yes, I know he's your enemy.
Do I have to kiss
It would be great to see you shake hands at the end of this battle.
I see.
Give us a handshake for the cameras. Thank you. There you go.
Yeah, I mean, part of the answer, Jens, is that the beauty of a motion device is the patient is finding their own center of rotation. You're not artificially doing it. You're not doing it by, just measurements of angles. You're actually allowing the patient to restore it. The only advantage we've seen to the differential lordotic angles in the inferior end plate, particularly at 5.1, has been to horizontalize that lower end plate so that it's not following a slope. It reduces some of the shear stress on the polyethylene. But that's been a good advance for us. But that's what we've seen necessary. We have not seen a necessity to build in more lordosis to the implants. In other words, we haven't had a lot of patients knocking on a door saying, the back of my implants are clicking and popping and wearing, and we haven't seen anywhere. In fact, the last time I was in Europe, I polled 100 French surgeons who had been doing this. I asked, how many of you have replaced an artificial disc for normal wear? And nobody raised their hand. So it doesn't happen. We've never seen measurable decrease in our height of our 25-year patients. So when they ask me still, what's the lifespan of the implant? I tell them, I don't know. They haven't been in humans long enough to tell you that they have a 70 or 80-year lifespan, but we can tell you that in 30 to 35 years in Europe and in 25 years here in the US, we have never seen measurable wear unless they're improperly implanted, unless there is edge wear, but that's almost always a technical issue, not an implant issue. So, my belief is these are lifetime implants. I don't have that longevity to tell them yet. But what I do say to them is if I'm wrong and in 40 years they all break, in 40 years when you're 80, your surgeon will figure something else out.
I'm trying to trigger Dr. Bervin. By the way, I want to point out, Ben, if you can go to the camera, we have our California Blues Bros here. The two suits of our two surgeons from California. Check out that.
Yeah, the only two
The
ties.
color coordination. Yeah, the color coordination of those blues. Here, put your arms together there. That's so cool. I mean, the Blues Brothers together. Look at that.
Insurance.
I wasn't part of that memo. You guys look great.
Oh, I love it.
Hugely admiring the strong work you're doing.
Jens?
Can each of you,
Yeah, it's
Yes. Oh, there he goes. Ladies and gentlemen, this is Gary, our judge.
beautiful, Gary.
Gary runs this immaculate lab. I have a pretty big nose, as you know, and I smell a lot.
You okay to
And this is
get
the
that
only
out?
anatomy lab that I can enter without any problems because
Okay.
there's literally no smell. It's immaculate.
we gotta go
Thank
to
you,
the
Gary,
next
for
session.
all you do.
Thank you very much.
can I ask a little question, Jens?